Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach, and this is another episode of Dadvice TV Live, where we talk with professionals about kidney disease to help you improve your quality of life and live longer. Now, tonight's topic is something that is important to all kidney patients and actually to people who don't have kidney disease. We're going to talk about heart disease and kidney disease. It's a very common combination. And well, I'm not going to give it away, but we're going to talk about risk factors for heart disease, and kidney disease is one of those. Now, my co-host is an expert. This is not just me, some random guy on YouTube saying, hey, here's what I think. We're getting experts here to help you. And tonight's conversation is going to be on the shorter side, but that means there's more time for your questions. So go ahead and enter in your questions in the comments. Just like Debbie here said, good evening. Hey, good evening, Debbie. Great to have you here. We got a lot of people already starting to say hello here. But my guess is you guys all know him. You all love him. He's probably one of your favorites on here, especially when it comes to answering questions. He is the author of my favorite kidney book out there, Learn the Facts About Kidney Disease. This book makes understanding kidney disease, knowing what you need to focus on, what you don't need to worry about, super easy to understand. And when I was diagnosed, I wished my doctor would have handed me this book, because in the beginning, like so many people out there, I was scared to death. I didn't know what I could eat, what I needed to do. I went online and I was worrying about all the wrong things, trying to lower creatinine and all this other stuff that is not really going to help you live longer, live better with kidney disease. So let's bring on my co-host, author of Learn the Facts About Kidney Disease, Dr. Steven Rosansky. Hey, Doc, how you doing?
I'm great, James. Good to be on your show. And yeah, James and I were just discussing another project that I'm working on that everybody, I assume, is interested in, and that is how to live as long as you can, but with the best quality of life. And a lot of the stuff that we discuss on James' Dadvice show has to do with lowering your risk factors for developing atherosclerotic cardiovascular disease, just like heart disease, heart attacks, and strokes, and so forth. Because those of you who watch this show know that for most of you, it's not dialysis or transplant that the majority of people with early stage kidney disease need to be concerned about. It's your risk factors, and it's getting one of these problems like heart disease or strokes and stuff like that. But do you want me to give my background and introduce myself?
Yeah, let's give a little bit of your background, because I see some new people already in the chat, and we need to make sure they understand you're the real thing to talk about kidney disease, the real thing to get advice from, because there's a whole bunch of people out there pushing what you and I both call woo-woo, which is not going to help you.
Right. I am a retired kidney specialist. I still go to the free clinic. I'll actually be there tomorrow. I've worked as a kidney specialist for over 40 years, taking care of thousands of different patients with various types of kidney disease and other medical diseases. I've also done a lot of research, and I've been recognized for my research in the area of when to start dialysis and in the area of factors that affect progression of your kidney disease. I've got over 100 publications, and I love being on the show. In my retirement, this is a lot of fun, and I think we're helping a lot of you folks out there to not be so worried about your kidney disease, because as I said a little while ago, for most of you, if you have CKD3, it's just a risk factor for atherosclerotic cardiovascular disease, heart disease. And tonight we're going to talk about the heart and the kidney. And this is a topic that I have been very interested in, because I could bet that there are lots of you folks out there who have both. because it is so common for people to have both. It is extremely common. About half of people that have been told they have heart disease also have kidney disease. But it's a certain type of kidney disease, and I think a lot of docs out there are not managing it correctly. And I think way too many people are coming into the hospital with heart problems, and they happen to have a kidney problem, and the docs don't know what to do, and they put them on dialysis, which is the wrong thing. And we're going to dig into that a little bit. So if you're ready, we'll go. And like I said, like James said, tonight, I don't have a lot of stuff to tell you, and I hope we'll have time to answer a lot of your questions.
Yep,
So
we are ready.
okay. So when you got a problem with your heart and your kidney, the kidney docs call it the cardiorenal syndrome, renal being renal disease, kidney disease, okay? And it's very common. Like I said, about half of people with heart failure have some degree of kidney disease. And the biggest problem is that about a third of people that get hospitalized with heart failure have James' favorite topic, AKI. James, tell them what that is.
That is an acute kidney injury, which means it is a temporary kidney injury. So your EGFR, your estimated kidney function, is going to drop, could drop really low. Maybe it's dehydration or something, but you can recover from that.
Right, exactly. And this is a really interesting situation. And I'm going to try to make it as simple as I can to tell you why the heart and the kidney are so closely tied. So you know that the heart pumps blood, and you know that the kidney gets a lot of that blood. And you know that you've got to get the blood to the kidney to get it to filter the blood.
Yep.
Which is called what, James? When the kidney filters the blood, we measure it by your what?
It's your glomerular filtration rate.
Exactly. The kidney filters the blood. It's the glomerular filtration rate. But you got to get blood going in there to get that filtrate that those amazing little glomeruli do. They filter the blood. And what happens when you have reduced work of your pump? Let's say your pump is not strong. What do you think? What do you think is going to happen to the kidneys?
Well, I like to think of it as your blood pressure, when it's accurate, it's what's powering your kidneys so they can filter. And having it too high or too low is not good. It's not the right power that it needs to function correctly.
Well, in heart failure, the kidney is reading not enough flow coming through. And there's a lot of reasons why that happens. And the kidney is going to work to respond to that. And if we're not getting enough flow in the kidney says, well, that means we need more volume, right? We need more volume in your body. So what is the kidney going to do? It's going to reabsorb water and salt. Yep. You're going to get a lot of water and salt going back into your body, going into your lungs, and that's called pulmonary edema, going into your extremities, that's called extremity edema. And we're going to get to this in a little bit, which a lot of docs that are not in the kidney world and are not up to date on this don't know that there's actually some of that fluid is swelling the kidney up. And that, in fact, may be part of the reason why you're not getting enough glomerular filtration. I think that's fascinating, right?
Yeah. So it's almost like a snowball effect. If it is too low, your kidneys are reacting to try to fix it, but you're just getting worse and worse.
Yeah, exactly. And what's happening is you're putting more of a load on your heart because you're getting, you're pumping against it. You actually raise your pressure because when your heart's weak, everything is going to go up. All the stuff we talk about, renin. Okay, The ACEs and the ARBs and the aldo antagonists. We got lots of shows on those. The ACEs, the prils, the ARBs, the TANs, right? The aldo antagonists like spironolactone. Those are the drugs that we've talked about numerous times. If you've got protein in the urine, and those drugs are good to slow your kidney function decline. But all that stuff, it's called renin and aldosterone. Those are the things that you're working against with these drugs. They go sky high. And your sympathetic nervous system, the fight or flight, response,
Yep.
those catecholamines, they're called, also turn on. So that's going to put more pressure on the heart. It's something called vasoconstriction. Blood vessels get narrower, and that heart's pumping hard. And so you get more strain on the heart. So it's kind of like James said, it's kind of like a vicious cycle. And so what happens is you go into the hospital, your GFR was 60, and now it's 20. Or your GFR was 30, and now it's 10. And what do a lot of the doctors do?
Dialysis.
Dialysis. Yes, James has been there.
Yeah, they wanted to do it in my neck.
Not with heart failure, but with his own situation, which was another AKI.
Yep.
But not from heart failure. So there's different things that can cause it, as James mentioned. So what most docs don't know is that you need to get more what they call diuresis. What does diuresis mean, James? If I say I need more diuresis.
Does that mean like a diuretic to get fluid out of you?
Yes, exactly. More diuresis. Get rid of salt and water. Simple. Get rid of salt and water. So the idea is, I love this term. You've got congestive kidney failure. In other words, there's a lot of fluid around that kidney envelope, which is compressing it. Part of it, all that extra fluid around the kidney and around the abdomen. And if you can get rid of some of that fluid, you can actually, theoretically, make kidney function improve. But the most important thing, and one reason why people will go on dialysis is they come in with heart failure and they've got kidney failure and they got fluid in their lungs, and a lot of times the docs are not giving the appropriate amount of diuretics, appropriate amount of diuresis. And I'm going to talk about what is the appropriate amount. And your GFR's down, you got a lot of fluid, and you may be having trouble breathing, and the docs will say, let's put them on dialysis, take the fluid off that way. My contention is that's a reasonable thing to do after you fail with what I call conservative therapy, meaning you try to use aggressive diuretic treatment, right? And you treat this congestive renal failure like congestive heart failure. Mm-hmm. It's a term that I think is interesting, which a lot of docs are just not aware of. And a lot of docs will hold the diuretics. They go, oh, the creatinine is up, I better not give diuretics. Oh, not such a smart idea, okay? And what I would do, though, is we know that the ACEs and the ARBs and even the SGLT2 drugs we talked about, they can cause a decrease in GFR themselves. But I'm not going to get into it tonight. But to not confuse things, I would hold them when you get in the hospital, you got an AKI, the doctor's talking about dialysis. Let's hold those drugs. Let's try to give diuretics. And let's see if I can breathe better. And let's see if we can avoid going on a machine.
And how quickly does a diuretic start to work? Okay,
good question. So you've heard of Lasix, I guess. Mm-hmm. It's a diuretic, or furosemide. Another diuretic that's very common that a lot of people that have high blood pressure on is called thiazide, hydrochlorothiazide. So
that's
Lasix,
one of mine.
and a lot of you folks out there are on that. It's a great drug to take along with whatever you're taking for blood pressure, and it can improve your blood pressure control. But furosemide can be in a pill form, and it's called it's in other words, how much of that pill is available to do the job on the kidney? About half. But if you give it IV, it's all available. So if you're really having trouble getting that fluid out, sometimes you need to give these drugs IV, like Lasix. And there's another one called bumetanide. And I've done this numerous times. You can get rid of 2 quarts of fluid a day, no problem. I mean, I've been more aggressive than that, but there are a lot of people who say, hey, you don't want to go too quick. You may harm the kidneys. It's theoretically possible. But you can easily get rid of 2 quarts, 2 liters. That would be like 5 pounds.
So you're removing then pressure on the lungs, pressure on the heart, pressure on the kidneys when you do that.
Yeah, you're what we're mainly when you're removing the fluid, the main 2 things that we're concerned about here is fluid in your lungs, which is keeping you from breathing well. Fluid builds up in your lungs. It's called pulmonary edema. That's very scary stuff. And the fluid around the kidney, compressing it so it's not filtering well. So those are the 2 main things. This is an aside that I'm doing a lot of research on longevity and various factors related to it for my next book. But apparently they found bumetanide, like Lasix, was associated with a lower risk of Alzheimer's. How do you like that?
Extra benefit.
A significant, it's just an association, but it's an interesting association. So if I were needing a diuretic, I would take bumetanide anyway, just off the record for it. So to get that fluid off, you use the loop diuretics, Lasix or bumetanide. Those are the two important ones. The hydrochlorothiazide has a limited effect. With Lasix, you can go up to, and I've done this, like the normal dose you folks out there may be on, if you're on Lasix, 20 milligrams, 40 milligrams. I've gone up to 240 milligrams intravenously every 6 to 8 hours.
Wow.
We're talking about, I mean, it's aggressive.
Yeah.
It's very aggressive. But it can, in some cases, in my experience, keep you from having to go on a machine. So, okay. What else can be done? If you've got heart failure and kidney failure, can you take a guess as to, okay, I'll just tell you. With kidney disease, a common hormone that we synthesize is down. It's called, remember, EPO, erythropoietin.
Erythropoietin, yeah.
And that's the stuff that can help red blood cell production. And what happens is the anemia is increasing the work. If you're not getting enough oxygen to your tissue, it's increasing the work of your heart. So you got heart. These are not for the AKI. This is treating you on the longer term. If you happen to have heart disease and kidney disease, you want to maximize both. You want to maximize your heart medicines and maximize your kidney medicines. Your kidney medicine for your heart would be EPO. And what's the goal? You remember, James, the goal, hemoglobin. It's not normal.
Was it 11 or 12?
Yeah, good, 11.
Okay.
Because what they found, you're good, James, what they found is when they tried to get it up to normal, which there was a study I was involved with. It was a heart failure RNS study, an Amgen study. They were trying to see if you get heart failure patients to get normal hemoglobins, and as we just talked about, you want to get good oxygen to your heart to help your heart out if you got heart failure. The results of it showed higher risk of other problems. What were the other problems? Higher risk of cancers, higher risk of strokes. So they decided to not try to go to normal levels. Interesting. And the other things, and when you're stable, when your GFR is stable, you need an ACE or an ARB, And some people think ACEs are better for heart failure. You need beta blockers, and you need the drugs that we've talked about that are amazing, called the SGLT2 drugs, the gliflozins like Invokana, canagliflozin, or Farzica. How do you spell it? How do you pronounce it?
Farzica,
Farx.
isn't it?
Is it Farzica? Is that how you pronounce it? Do you
I
pronounce the
believe
X?
so.
Okay, Farzica or dapagliflozin or Jardans.
I just list them all down in the notes after the show. I have a
Yeah,
list of them, those, and then the GLP-1s also.
these drugs are SGLT2 drugs are longevity drugs. Why? Because they decrease your likelihood of dying from heart disease, as well as slow decline of kidney function, as well as treats diabetes. These drugs are great. They have a lot of good effects. The other thing that if you've got really bad heart failure, you may need to be on low sodium. And you may get to the point, if you can't get the fluid off, you have to get some fluid and salt restriction. And if you are, I can't, like I told James, I don't think we have a show without mentioning exercise. And if you've got heart disease, an exercise program can help improve your heart health. So we are not stressed tonight for time, so we can relax and try to slowly answer questions.
Yeah, that sounds good. And I want to mention one thing about
Yeah.
exercise. It's free. It can be fun. It can be anything as simple as walking. And those of you who have been watching me from the beginning, you know there's a video that I own. I used to own it on VHS, and I got it on DVD. Now I have it purchased online so I can watch it. That I love getting out and exercising to, and that's Richard Simmons dancing to or sweating to the oldies. Love it. Sad that he passed recently, but I find his videos great. They're fun. You got music, and then also using some tech. I have a VR headset, and there is a game called Beat Saber. You're just using lightsabers and moving and ducking and stuff. It is a ton of fun, and you're doing it all to music. So, enjoyable, easy way to exercise, but exercise could be as simple as walking the dog, gardening, even just doing work around the house, just getting up, moving, being active. You don't got to be weightlifting at the gym or anything like that to get exercise. All right. And I was hoping that would give people time to write some questions that they want to have you ask.
Yeah. Well, let me throw in, we could talk the rest of the half hour on exercise, but I'll throw in just one thing. Those of you watching the show who are having desk jobs, your lack of exercise at your desk is killing you. Literally, there's good data. What do you do about it? Simple. Every 30 minutes sitting down at your computer, get up and walk around for 5 minutes. Walk the stairs. Get up and down out of your chair. And the biggest thing, look, I go to the gym every day. So for me, it's second nature. I get it. It's not easy to start an exercise program. But all of you can do it. Start slowly. Start with a buddy. Do something fun, like James said. You can just play with your kids. You can do gardening. Anything that gets you moving. The easiest one is walking. The easiest one. 10,000 steps can be a goal. Nothing absolutely magic, but that's a reasonable goal. 30 minutes, 5 times a week would be great. It will help you live longer. It will help your brain function. It will help your heart function. And we can go on and on. Okay, let's see if we got any questions from either you or...
Why don't you scan through the questions, and I'm going to throw in a couple more tips of things I do to try to help get extra steps in. 2 things is I never park up close. I park far away so that I can walk, get that little extra, those few extra steps, walking to the store. And when I'm at work, I've now made it a habit when I'm booking a meeting room, I look at the building map and I pick a room that's far away. So I have to walk to it and then come back to my desk. I don't pick the rooms that are, right there in arm's length. That way I can get some steps throughout the day.
All right, we will take our first question. Purple pea. Purple pea, James. What do you think?
I have never heard of purple pea. I would say, what are you eating?
I would totally agree, James. Purple pea, what are you eating? Now, it is possible that somebody thinks purple I would call red. So it would not be unreasonable to check for blood. And as we've said on the show, you can buy dipsticks for protein and blood and infection that will check for infection from Amazon. Okay.
I'm
What
seeing questions
about
come in.
your? Can you lower your BUN number? I'm going to let James answer that.
So don't worry about your BUN, but if you go from eating lots of meat to eating vegetarian foods, lots of fruits and vegetables, for me, I see that cause my BUN to go down, but it's not something to worry about. It's your blood urea nitrogen level.
Right. The blood urea nitrogen level is something that sophisticated, educated, informed docs can use as a marker of things beyond kidney disease. Back in the, I don't know, probably 50s, before creatinine became a regular lab test, the creatinine is the marker that most labs use to measure your GFR. We used to use your blood urea nitrogen. It does have something to do with your kidney disease, kidney function. But in order to be a good marker of kidney function, you need something that is what? Filtered, but not reabsorbed, okay, and not secreted. In other words, it goes, you want to measure filtration, but if you got something that you've got a lot of reabsorption, right? It's not just filtered, it goes back into the blood. That's what BUN does. A lot of BUN values can go up when you are in situations of heart failure, dehydration, and it can have you. I've seen people in heart failure with BUNs of 200. Normal is 10 to 20, with a creatinine of 2. So the BUN can actually tell your doctor things like, is it heart failure? Like James said, BUN is blood urea nitrogen, and it's the nitrogen that comes from the protein you eat. You eat a lot of protein, you're going to have more BUN. You eat very little protein, you're going to have less BUN. And I will plug, do not fall for the very low protein diets and the protein supplements, the amino acid supplements. Not good for your health, not good for your longevity. It does not really give you any, in my opinion, significant kidney benefit.
Can you talk about bubbles in the urine? This is something we get asked about quite often.
Yeah, well, I don't know where that came from and why that became such a topic.
It's on all the kidney message boards.
Well, I mean, there may be a relationship between having a lot of protein in the urine and having foamy urine, but I don't know whether that's been quantified, and I can't tell you for a fact. So, it doesn't, basically, it doesn't mean anything. And Rosa, I'm glad that you love us when you heard about your CKD3. And it's always worth mentioning that CKD3 for most folks is not going to mean dialysis or transplant. It may be 1 out of 10,000. And unless, of course, you're one of those people that have significant protein in the urine, like 1 to 2 plus consistently on the dipstick, or over 200 on your albumin creatinine ratio in the U.S. or 20 outside the U.S.
I have a follow-up from Rosa that I'd like you to address. She says her GFR was 38. Then her last labs, it was 37, and that scared her.
Oh, wow. James, are you scared?
Nope. To me, that's stable. Because it's going to do this, and that's still in the same range. It's the trend. That's what we look for.
Yeah, we both laugh at this because we've talked about this many times. Your number is not a real number. Don't worry about any one number. The number, and this has been shown by a lot of research, the number can be, let's say your number was 30. Your real number is anywhere between 25 to 35, or maybe even a wider range. But it's not necessarily that number. And don't go by small changes. As James said, it's the trend over years and certainly months that matters. Okay. So kidney cancer, held off dialysis. Okay. So Lucille, you had kidney cancer. You held off dialysis. Now, I guess your creatinine was 6. So, did they have to remove your kidneys? You can have kidney failure because they had to remove kidneys, or I don't know what the cause of your kidney failure is. But Lucille, this leg swollen, tonight's discussion is something that you should address with your doctor. Are you getting enough of the diuretics? Can you get rid of the fluid by giving the right amount of Lasix or Bumex or any of the other combination of diuretics? So not necessarily start dialysis. Ask your doc if that's the reason. I mean, to me, just because your creatinine is 6 and your GFR, let's say, is 10 or to 15, unless there's a good indication to start, like you can't get rid of the fluid, you're having trouble breathing, I personally would try to get rid of the fluid without dialysis. So somebody said the creatinine was normal, he increased the blood pressure, metoprolol. I'm not sure if there's a question there. Yeah, plant diet, I am all for it. I think there's no need to get on crazy diets. You don't need to fast. You don't need keto diets. You just try to, simple, eat as much plant stuff as you can get. Eat fish several times a week. Stay away from the red meat. Eat nuts. Use olive oil. Lots of olive oil. This definitely is beneficial. Okay, so that's the diet. Okay. I think we don't have too many. I just started dialysis, have a line. Okay, well, good luck, Lewis.
Okay, here's one. Someone says, do you need to fast for your blood work?
You do need to fast for your lipids and for your glucose. Because if you eat before you have your blood drawn, you're not going to know the thing your doctor wants to know. What's your fasting blood sugar? The fasting blood sugar is the main way that we diagnose whether you're having a glucose intolerance, a diabetes kind of situation. And it's that in the A1C. If you have an abnormal fasting glucose, then the next test would be an A1C, which is a measure of your average glucose over the last 3 months. And triglycerides are going to go up if you eat. So they're not going to be reflecting what the real level is. And I've seen a lot of people have triglycerides, which should be somewhere around 50 to 100, like 500 or more after having a fatty meal. It just goes to show you what it does.
Yep. We have one here. Someone says, is it possible to ever come off of dialysis? I get this question almost every day emailed to me.
I have had several patients of my own that have come off dialysis. I have had friends who had people that came off dialysis. Here's here's what you got to do. You've got to have a doctor that's going to work with you, and you got to have good urine output. What is good urine output? Putting out like at least a quart of urine a day. You've got to have the ability to not get swollen up, breathe okay, not have fluid in your lungs. If you can maintain your fluid balance, you're not having trouble with high potassium, you're eating okay, you can get your doctor to check what your remaining kidney function is. One of the problems with starting people too early on dialysis, which I've seen a lot, is your remaining kidney function will decline quickly. So you need to have a doctor that's willing to check what your remaining kidney function is willing to have you come in at least once a week, check your labs, make sure you're feeling okay, and see whether or not it's appropriate for you to stay off the machine. Now, one of the situations, and we talked about this tonight, where it would be very appropriate is if you have people with AKI, right? Mm-hmm. You have a short-term, like a heart failure patient, congestive heart failure, GFR went down to 10, your heart got better. You may not need to stay on dialysis as long as you can maintain yourself on diuretics, you're breathing okay. But look, I've done this myself, and I know a lot of my colleagues do it. It's a lot easier to not have to mess with, hey, what's your remaining kidney function? Can I take you off the machine? I mean, once you're on a dialysis program, it's a lot easier to get the doc to manage you that way. They see you 3 times a week. It's a no-brainer. They get paid a lot of money. I mean, it's win-win. So to get off dialysis is hard. To not start dialysis when you're being pushed to is also hard. But you need to read my book, bring it up to your doctor. I've got a lot of information that you can bring to your doctor and see whether your doctor would agree.
All right, here is a great question. Willie is new, and he's asking, is there a way to test your urine at home?
Say again? Is it okay?
Willie, he's new, and he'd like to know, is there a way to test your urine at home?
Oh, sure, yeah. And James, I think, has purchased them, and yep. there are these strips on Amazon, urine test strips. You can go to Amazon, get urine test strips, and they test for protein in the urine. They test for blood in the urine. The key thing is protein, and they'll test to see if you have infection. Now, Elizabeth, this is kind of interesting. Elizabeth is talking about stage 3, and she had some uveitis. I don't think they're related. There are genetic, inherited diseases of the eyes and kidneys, of the ears and kidneys, but certainly that's not likely to be what you've got. Okay. Yeah. So I'm happy that Raj has a plant-based diet, excellent. Good quality of life, excellent. Stage 4, diabetic, excellent. And high blood pressure. The one thing, Raj, I will give you a tip on is that you got to be careful when you have stage 4, and certainly stage 5, CKD, that you don't overtreat your diabetes, because low sugar is very common. So be careful. And your goal A1C by the International Kidney Doctors Organization is not 6 or 7. It's closer to 8. So be careful. Okay.
Raj had a question. How do you screen for heart disease?
Okay, it's a very good question. We don't have an easy answer for that. Here's a couple things. Um, if you are, and this is happening as you get older. As we get older, everything wears out. As we get older, we talked about this. Normal kidney function for someone 70 or 80 may be CKD 3A, 45 to 60 GFR. Your heart function may not be as good as you get older. So, but if you're starting to have shortness of breath on exertion, you're having difficulties climbing stairs that you used to be able to do, you're starting to see swelling, especially in your lower extremities. And the best thing that I recommend is take your finger, your index finger, and stick it above your ankle. And just leave it there. Press hard. And if you can indent it, that means you have edema. That could be a telltale sign of kidney disease and heart disease, as we discussed earlier. And go to your doctor. And they have certain tests that they do to measure the heart function. But to see whether you're having symptoms related to it, those are some of the symptoms that may indicate that you may have some congestive heart failure. Now, Yamoto went off the Farzica, however you say it. Now, I'm on Trulicity. Which one is Trulicity? Do you happen to know?
Trulicity. Hold on, let me look it up.
Okay, so going back over it. So here's the thing uh, with the SGLT2, the Farzica, is that you can get loss of salt and water. It can get you to be volume depleted. So if you're sick, you have an infection, they may stop it temporarily. I don't know why they would stop it long term. And if you've got protein in the urine, I think it's a good drug. Is Trulicity an SGLT2 or is it GLP-1?
It's a glutide.
It's a semiglutide.
Yeah.
Well, yeah, I'm not sure. Okay, so it's probably okay. I'm not sure why the switch was made. There's a lot more data on the SGLT2s, the Farzica type drugs, than the GLP-1s for people with kidney disease and protein in the urine.
Yeah, the Trulicity is very similar to Ozempic.
Yeah, I mean, I don't know if it's given to treat diabetes and proteinuria,
Yep.
or for weight
Type 2
loss.
diabetes.
No, but I'm saying for this particular patient, I'm not
Yeah.
sure why they. I don't know what the indication was. Okay. Um, yeah. Vincent used to walk around the block after eating Nathan's. I like that.
I did. I used to, when I was in Cincinnati, every day before lunch, I'd walk around the building, which is 1 mile, go get my lunch, and then walk around the building again. I did so good back then.
That's fine. I mean, I'm good with exercise. I'm not so good with Nathan's, but okay. As long as you get the exercise, I'm good. Um, Rosa CKD 3B has heart trouble. Yeah. Rosa, I don't know what the heart trouble is, but as we said here earlier, it is extremely common. And like we said, around half of the people with heart failure have some degree of abnormal kidney function. Somebody's hemoglobin is around 10 on dialysis. Okay, Lucille, when you're on dialysis, your docs are going to not only follow your hemoglobin, but they're going to follow your iron and your total iron binding capacity. In order for the EPO to work, you need to have enough iron. And in the dialysis unit, we would transfuse the iron as opposed to taking the pills to make sure you get adequate iron. And we would do it routinely. Follow your iron, you get your iron sat down, we give you IV iron. So your doc needs to know if you're on the right dose of your EPO type drug and what your iron studies showed. Is more potassium okay for blood pressure? Yes, the prophet. Too many people with kidney disease, especially early kidney disease, stage 3, worry about potassium. Potassium has all kinds of benefits. Plant-based diets are high in potassium. Potassium has a relationship to lower incidence of strokes, lower blood pressure. It is good for you unless it gets in the 5.5 to 6 range, then you got to start being concerned. So my thing, and we talked about this on various other shows, plant-based diet, how do you know whether you need to start worrying about potassium? Monitor your potassium. If your potassium starts to become a problem, then you can consider whether you need to restrict it. Okay. Somebody went on a potassium binder. That's interesting. Okay, yeah. So, I mean, you don't necessarily, again, Raj, you're on a potassium binder, and the time that I would be more inclined to use it would not be just to be on a plant-based diet. But if you are one of these people that needs to be on an ACE or an ARB or an SGLT2 to slow your decline, that's when I would consider using the potassium binder. You might be able to get off it. You just have to have your potassium monitored. My kidney doc said I can't lower my BUN number. Okay. Does inflammation drugs hurt your kidney? I'm not sure what you mean by inflammation drug. Well, I think maybe what you mean is NSAIDs. These are anti-inflammatory, non-steroidal anti-inflammatory drugs. NSAID, non-steroidal anti-inflammatory drugs. Give us a few names, James.
Ibuprofen.
Yeah.
Advil.
Motrin. Yeah. Okay. Those things can definitely cause you to have a decline in your kidney function. Probably one of the commonest combinations of lowering GFR are people that get somewhat dehydrated and are taking NSAIDs. So maybe that's what you're referring to. Yeah, I don't know. Look, Vincent's talking about Ozempic and long-term risk. I'm with you on that. I think the GLP-1s, the weight loss drugs, they've done a lot of good for a lot of people. But we don't know the long-term effects. And frankly, just because you have extra pounds doesn't necessarily mean it's going to shorten your life. There are healthy obese people. And I think it's good to consider taking these drugs. Most people have to stay on them because they'll gain the weight back. My advice is try to get on the lowest dose you can and try to get off them. You got to combine lifestyle with any weight loss regimen. You can't just be taking the drugs or be on the diet because it won't last. You've got to combine it with habit, just like getting in the habit to exercise, getting in the habit to eat the right foods. Okay. All right. What drugs help protein besides BP meds?
Oh, that's a good one.
Debbie's on. Let me just. Anyway.
What drugs help reduce the protein in your urine besides?
Yeah. So
ACEs and ARBs.
Okay, Debbie, if you have protein in your urine, a lisinopril dose of 2.5 is not the right dose. You need to be on the maximum dose, which is, I don't know, it's more like 100 milligrams. So the first thing to do is if you are a patient out there with significant protein in the urine, and we look at some of our other talks to see what we mean by significant. The first thing to do is be on the maximum dose of an ACE or an ARB. The next step is to be on an SGLT2. The next step would be on one of the aldo antagonists, and then the last step may be a GLP-1. But you're not on the appropriate amount of the first step, so that's what needs to be attended to. Antibiotics can hurt the kidneys, but most do not.
Well, someone asked what antibiotics will not hurt.
Yeah, most of the antibiotics you take today are going to be fine. There is such a thing as an allergic reaction. It's called interstitial nephritis. So rarely any antibiotic can cause you to have kidney failure, but that's very, very rare. So most antibiotics are fine. Most doctors know which of the antibiotics uh, are potentially harmful to the kidneys, and they're only used in the hospital, pretty much. Uh, and
Someone asked for the title of your book, and it's Learn the Facts About Kidney Disease. I also put it there in the chat. You can order it from Amazon, your local bookstore, any place that you order books, you can get a copy of it.
Yeah, Giovanni, in terms of the time on dialysis, again, you should have your clinic assess your residual kidney function. If you've got adequate residual kidney function, you may not need to be on dialysis. If you've got minimal residual kidney function, the minimum dialysis is probably 3 times a week, 3 to 4 hours. Okay.
This is the most questions we've ever been able to get through in one of these broadcasts. This is great.
Yeah.
If you guys have questions, type them in. We still got a few minutes left.
Yeah. So somebody's talking about, well, I'm not going to get into the hemp issue. Look, I don't think there's any evidence for hemp. No good, solid evidence, but I'm not an expert on it, so I won't, I won't get into it. So Rosa said, you said I can wait until GFR is 10 before starting dialysis. Well, okay. Rosa, it's a complicated question. Please read the section of my book where I go into great detail about it. And my research, to just summarize it quickly, and by the way, my research was voted the #1 game changer in nephrology in 2011. So people felt it was a very significant piece of research. And what we found, that starting dialysis early may be harmful. Early was over 10, roughly. Now, there are some people that need to start early because they have what we talked about tonight, kidney failure and heart failure. And they're not able to manage their fluids with diuretics. And so they just can't get by. But Rosa, she says 75, I guess.
Yep, 75 years old.
Yeah, yeah. So, I mean, I would look at my book, go to your doctor, say, hey, Dr. Rosansky said that the Kidney International Organization is suggesting that before starting dialysis, there needs to be a reason for it. Now, somewhere between GFR 5 and 10 is a range to be looking to see if you've got a reason to start dialysis. But just that number alone, I would not personally be willing to go on to dialysis. You need to have some other reason besides just your number. So Ray has an A1C of 5.7 and stage 4 CKD. You do not have diabetes, and I think if you're on diabetes medicines, there's more of a risk than any benefit. So I would not be on it. Yeah, you could do, I know people that did running that were on PD, certainly not contraindicated, unless you're having some kind of you're not running with your fluid, you run dry. I mean, but that's something you have to talk to your dialysis folks. If you've got Care has unilateral right ankle, just one, that's not usually a sign of heart failure or kidney failure. It could be the veins in your legs that are causing you to have that problem. Okay, let's see. See anything else?
There
and
was.
Weight control. Okay, someone says control edema without diuretics. Okay, look, we all know that when we're standing a long time, we swell up. So if you're
Gravity.
lying down, you're going to actually, what happens is when you lie down, you're going to actually have some of that fluid going to your heart, and you're going to have to get up and pee. So you're going to pee out some of that extra fluid. But no, the best way to get rid of it is diuretics. Someone says a high potassium and my potassium levels right on the line.
Here's one. Someone says, what can they do for bad constipation? And that's a question I see quite often.
Okay, I am a big fan of fiber. You could take fiber pills, but the best source of fiber is a plant-based diet. You eat a lot of fiber and drink a lot of water, assuming you're not on water restriction. That is the best way to keep your bowels regular. And so try to eat lots of fruits and vegetables, fiber, and fiber pills are good too. What is Valtessa? I forgot. Valtessa? James?
Let me find it real quick.
No, I forgot it. It's Valtessa. I can't remember. It's taking it 3 times a week. Someone's got puffiness under your eyes. Okay. Kara, I don't know whether you have protein in the urine, but it can show up as puffiness under the eyes if you've got a lot of fluid in your body. But beyond that, drinking water is not a good idea to help it.
And Valtessa is a blood pressure medication.
Which one is it?
The Valtassa.
Yeah.
Is a blood pressure. It is Patiromer.
Okay, I have to look at it. How do you spell it?
The VELTASSA, and the other name, the real name is PATIROMER. I have never heard of that one.
Okay, hang on a second.
Hyperkalemia, also for high levels of potassium.
Oh, okay, yeah, it's a potassium binder. I knew.
Yeah, there we go.
It's the potassium. So who was asking about Valtessa? I totally lost it. Okay, so you look that up. I'll go. That's just a potassium binder. Somebody says, I think BP meds only help kidneys because they lower your blood pressure. Some meds can be bad that are for kidneys that are stressed. I don't know. That doesn't make any sense. The only thing that makes sense is do not allow your blood pressure to get too low. And I've talked about this many times. If you are on blood pressure, you want to get your goal 110 to 120. If you are feeling dizzy or weak, especially when you stand up, check your blood pressure. There is no blood pressure medicine, to my knowledge, that's bad for your kidneys. The only time it can be bad for your kidneys is if you lower your blood pressure too much.
All right, I found that question. It was Philandus Williams. He says he's on a low potassium diet. He's taking that binder 3 times a week.
Yeah.
And he wants to know, is it possible to come off of the low potassium diet?
Yeah. Again, it's just monitoring your potassium. And what I would do is I would get off the Valtessa and see whether you have to be on low potassium. It's stuff you got to do with your dietitian and your doctor. The first thing I would try to do is get off the Valtessa, see if your potassium is good. Then I would continue to try to increase my plant-based diet. And if you can't, then go back on the Valtessa.
All right, here's a question for me, and we're out of time, but I'm going to answer this one from Diamond Blue. It says, James, what fiber do you recommend? So when I first was diagnosed, it was difficult for me to get enough fiber in my diet, and my doctor recommended like Metamucil. But I now get plenty of fiber in my diet. I eat watermelon, cantaloupe, honeydew, all sorts of other foods that are, have fiber in them. Apple. I love apples. That's probably my favorite source. They also I still take ProRenal plus D, which is a renal multivitamin. Yes, I do. And Renadil, I do take that still. That is a probiotic for, just specifically designed for kidney patients. All those were recommended by my dietitian and doctor, and I take all that. But I try to get all my fiber now from food, not from stuff I sprinkle on my food.
Somebody asked about vitamins. You just mentioned vitamins for kidney patients.
Yep.
James, I don't think most people eat a good diet need vitamins, but you should get, if you've got, especially a CKD 4 or 5, you can't take a regular vitamin pill because some of those vitamins will accumulate if you've got a significant kidney disease. And yeah, this is Christina, 75, GFR9, no symptoms. Again, ask your doctor about whether or not, look over my my book and say, why do you need to start me on dialysis? It should not be just for a number of GFR9.
Okay. Very good. And I grabbed one of my bottles of the ProRenal Plus D, which is designed for kidney patients. It's got the National Kidney Foundation, a bunch of other kidney organizations recommend it because it's got the things that, or it does not have the things that we should not be having with kidney disease, things that can build up.
Especially vitamin A, which can be toxic. Yep. Yeah.
All right. I'm going to plug your book one more time for those that are out there. They're like, oh, what was Dr. Rowe's book again? His book is Learn the Facts About Kidney Disease. Super easy. Pardon me. Super easy to understand book. If you're worried about kidney disease, this is the book that's going to have you go, whew, oh, thank goodness I don't have to worry. Here's what I need to focus on. It is a super easy read. It is written for people like us, not for people like Dr. Rowe that knows all the technical terms. I've purchased so many kidney books, and some of them, I can't make it through it. I'm like, I need a thesaurus to look up all these medical terms to figure out what the heck they're talking about. We don't have that problem with Dr. Rowe's book. It's very easy to get. Someone's asking, how can you get it? Amazon. Just search for Learn the Facts About Kidney Disease, or Dr. Rosansky's name, easier to spell, Learn the Facts About Kidney Disease, to find it in there. All right, Doc, thank you so much for all the questions today. This is great that we had so much time to go through lots of questions. I will be back in 2 weeks with renal dietitian Jen Hernandez. And then in mid-August, I have another special guest who we are going to talk about a new program to help people find living kidney donors. And it's an amazing program that is being tested in some areas. And I am so excited to see the success it is helping find living kidney donors. That will be coming up. I'll be promoting that a lot once we have the exact date so that everyone can watch that. Even if you don't need a kidney right now, it talks about what you can do to help others in need of a kidney transplant to find their donors. And the stats and the data is just heartbreaking for the amount of people out there needing a kidney. We have enough people that can donate to solve that problem, but they're just not aware of it, and they're not, it's not something that they think about. Anyway, that's coming up. All right. Thanks again, Dr. Rowe. Thank you so much, everyone out there, and we will see you again in the very near future. Bye, everyone.